This video continues Chapter 23 of OEC6, Chest Trauma, by specifically looking at the assessment of a patient who has experienced chest trauma. A couple of key terms to consider here. We'll be referring to what we saw with chest injuries, in particular, observing for paradoxical motion. So with patient assessment, we stay with our assessment algorithm, and that is begin with a scene size up and make sure that you practice scene safety, mitigate any hazards, and apply BSI, body substance isolation, standard precautions. We also want to take a look at MOI, and as a final piece, make sure that we get the chief complaint. Because from that chief complaint, understanding that a chest trauma may occur, we can consider working through the ABCDs and correcting life threats. That may require us to open the airway, assess the patient for adequate breathing and oxygenation, and really take a look at rate and quality of respirations. A high rate of respiration could indicate potential shock, and the quality of respirations, if they're shallow or the patient is guarding, we may understand that they're in some sort of respiratory distress. The pulse is always something that we want to check initially, even if we're just looking for presence and adequacy, and then consider mental state. Now, part of that scene size up and primary assessment can be also to look at the patient's overall appearance and skin color. Are they pink, warm, and dry, or are they pale, cool, and clammy, indicating potentially some hypoxia? We may notice traumatic asphyxia if the patient's eyes are starting to bulge outward. We may notice that the neck veins are distended, which could suggest pneumothorax or pericardial tamponade as the mediastinum has been shifted. This will also appear as a shifting of the trachea. These may also blur a little bit between primary assessment, that scene size up and looking at the patient's overall appearance, and a quality head-to-toe assessment. Continuing in secondary assessment and that head-to-toe, when we get to the thorax, the chest, ask the patient to take a deep breath and then exhale, and we're going to observe for equal and symmetrical movement or any grimacing that occurs because of the pain, say for a rib fracture. If you're in a clinic and have a stethoscope, this may be part of our auscultation, listening to the lungs and the breath sounds. Don't waste precious time for a particular injury. If we have some sort of a life threat due to the chest injury, let's just move them. Now, we can dive in deeper to this idea of chest assessment and the LAP method. Look, auscultate, and palpate. So when we look in secondary assessment, we'll still stay with our secondary assessment and our DCAP bottles. Perhaps we see bruising on the chest wall, which could indicate a potentially serious injury underneath. We're looking for P, penetrations or punctures in the case of an open chest wound or an impaled object. We may notice a flail segment and that paradoxical motion. We can look for full inflation of the chest and symmetrical movement for possibly rib fractures, not just multiple rib fractures in multiple locations, such as a flail chest, but even a simpler one. Auscultation, that is listening to the breath sounds with a stethoscope, may reveal gurgling or wheezing or some abnormal sound. We don't need to understand all of these differences, but we should be able to distinguish them from a normal breath sound and just consider that this is somehow abnormal, that something isn't right with their respiratory system. Make sure that the breath sounds are equal on both sides and avoid any of these abnormalities. Now finally, in terms of palpation, what we'll do is just make sure we check the clavicles with our fingertips all the way completely. We may look for fractures involving the scapula because this large bone on the back is typically going to require a significant amount of force. And we can assess the integrity of the sternum using fingertips or the flat side of our hand, always being aware of patient dignity in this case. And then finally, we can encircle the rib cage with both hands, Apply moderate inward pressure on the lateral walls of the rib cage and just have the patient take a deep breath. Again, moderate pressure on the sternum, allowing the patient to take a deep breath. Pain on either one of those tests, stop. So LAP, look, auscultate, and palpate. Vital signs are a critical part of our secondary assessment as well, and we'll want to reassess those and look at serial vital signs over time in the case of suspected chest trauma, because we want to look for the progression of shock, and we may pay close attention to pulse pressure, that is, a narrowing between the systolic and the diastolic pressures. If we see the distance between those starting to get narrower, consider the possibility of pericardial tamponade. We can summarize all of the signs and symptoms of chest trauma this way, and we can consider, in the case of secondary assessment, looking for all of our decap bottles sorts of things. We may consider, when we look at vital signs, the idea of tachypnea, rapid breathing. We may consider part of our scene size up, looking at the patient condition, and in the case of vital signs again, falling blood pressure as a possible sign of chest trauma.